I would have hoped to be able to see you in person in India, but it's my great pleasure and privilege to be able to talk to you today about weight regain after bariatric surgery, and I would like to thank the association for the kind invitation. This is my disclosure slide, and it has no bearing on the presentation. I'm going to speak to you today about four main things. How do you decide when to offer patients revisional surgery? Do morbidly obese patients behave like super obese patients? And does it make sense to stage patients with BMI over 50? And what are the options for sleeve gastrectomy for weight regain, since it's the most common operation that we perform today? So I think it's important to note that the causes for weight regain are multifactorial as listed in this slide. And from the Swedish obesity subject study, we've learned that weight regain is actually a natural process after bariatric surgery when patients reach their nadir at about year 1. And typically between year 1 and year 10, depending on the surgery and the patient's BMI, there is some weight regain. And this has been shown also by a study by Dr. Olson matching patients to bariatric surgery or mainly Roux-en-Y gastric bypass and non-surgical options. You can see some weight regain between year 1 and year 6. So weight regain is a natural process, and as you can see, sleeve gastrectomy is different than band, different than bypass in blue. So the question is, what is significant weight regain? There's really no well-recognized definition for weight regain, and as you all know, we don't want to use words like failure in bariatric surgery. When you look at inadequate weight loss or weight regain, most studies give no definition, but the most frequently cited definition, due to the lack of a better one, is the Reynolds criteria of an excess weight loss with 50%, knowing that excess weight loss in of itself is actually not a good way to look at weight regain. Second most common is less than 25% excess weight loss, again, using excess weight loss. So criteria has to look at whether you look at BMI of 30, 35, whether you look at excess weight loss or total weight loss. And I think it's important to look at the standardized outcomes reporting by the ASMBS that came about in 2015, led by Stacy Bretthauer. And in this, we try to agree on a standardized way. So we need to report change in BMI, and you might have noticed in journals asking for this specifically. You need to report total weight loss, just like our medical colleagues, rather than excess weight loss. And you need to report percent excess BMI loss. And if you include excess weight loss as well, that's okay. I think this is where we need to start, is defining exactly what weight regain is to be able to actually make a statement. The second thing is, there was a recent study by your group from the Indian Bariatric Surgery Outcome Group, Sumit Shah, Kamal Mahawar, Dr. Priya, and Sarfaraz Page, and they looked at a multi-center study of 26 high-volume centers with 32 bariatric surgeons and more than 9,500 patients. And they found that there was weight regain depending on the procedure, and it was 35% in sleeve, 14.6% in Roux-en-Y gastric bypass, and only 3% in one anastomosis gastric bypass. And they used an increase of 25% from weight loss of the nadir, and then they used also either weight gain of 10 kilograms or 5 kilograms. And in this study, they found that the procedures are different, as I said, and also preoperative BMI makes a role. And I think this is one of the excellent large studies looking at weight regain in patients after bariatric surgery. And they concluded that one anastomosis gastric bypass has less weight regain, but had the most impact on micronutrient deficiencies. So again, it's always the balance of weight loss versus complications in terms of nutritional deficiencies. Also, there is no clear definition on reoperative surgery. So when you say I've revised the procedure, I'm doing a revision of the procedure, what does that mean? ASMBS also in 2014, led by Stacy Bretthauer and John Morton, tried to put definitions on reoperative surgery, and this is the accepted definition that we should use: reversal, conversion, or correction. And this is important because reoperative surgery, as I'll show you, has higher rate of complications and lower weight loss than primary bariatric surgery. So when you operate, you have to balance the risk of surgery as well as the risk of nutritional deficiencies versus the benefits. That is why first you need to know what's the starting BMI before primary bariatric surgery, meaning did the patient get the best operation that they needed at the first time? Second, did the patient maintain 10% total weight loss, which is known to have significant cardiovascular benefits? Is the patient a high-risk patient? Is the patient now 71 or with multiple medical problems, cardiopulmonary or the like, and that actually might lead you to decide to offer or not offer surgery? What is the current BMI? Does the patient currently meet criteria to have bariatric surgery, or the main driver is just weight? Does the patient have comorbidities right now? Is the patient diabetic, hypertensive? Do they have sleep apnea? And does the patient have reflux? And if the patient has reflux, what is the objective assessment of the reflux? Do they have Barrett's? Do they have dysphagia? Do they need to have a manometry? And again, what's the multidisciplinary assessment of the patient? What's their laboratory studies right now? Are they anemic? Do they have vitamin deficiency? And how compliant were they when they had their first surgery? All these questions will make you decide what to do with the patient. So again, the next item is we want to talk about is, do obese patients behave just like super obese patients? And I'll tell you, in my opinion, super obese patients are like stage 3 and 4 cancer. And they don't need more aggressive surgeries. They need a multidisciplinary approach and multimodal treatment. So there's been several studies to show that your likelihood to have a BMI of less than 30 is linked to your preoperative BMI, like this excellent study from JAMA with more than 9,700 patients. In addition, if you look at the average BMI after bariatric surgery, each procedure has an expected average BMI, whether it's sleeve or Roux-en-Y gastric bypass, with sleeve and band being less effective, with band being less effective than sleeve and Roux-en-Y gastric bypass. And in general, it's anywhere between 12 and 17 BMI points. Kelvin Higa's group looked at 10-year follow-up after Roux-en-Y gastric bypass, and when they divided patients with the preoperative BMI, you got almost 2 different procedures because of the preoperative BMI, even though they had the same surgery by the same operators. And if you look at super obese patients long term, you can tell that not every surgery is appropriate for them. So if you do a sleeve gastrectomy in a super obese patient, they're not going to fare as well as if you do a Roux-en-Y gastric bypass in this matched analysis of a small study published in 2018. And in our own group, we looked at the outcomes of Roux-en-Y gastric bypass and sleeve in super obese. And even though both of them have some weight regain, it was much more evident in sleeve gastrectomy compared to Roux-en-Y gastric bypass. So the next item I wanted to cover is, should we have a staged approach to super obesity? And practicing in the US, this is not very practical. And what's wrong with doing a sleeve and then coming back, like many authors say, re-sleeving or converting patients, and there's so many options. The notion of doing staged surgery is not practical. In the US, many insurance companies allow only 1 bariatric procedure per lifetime, and generally the complications of reoperative surgery and the outcomes are not as good as the primary surgery. So I think this approach is not used a lot in medicine, and I would not recommend this approach, especially because we now have a tsunami of sleeve gastrectomy patients. How many of them do we need to do something again? And these numbers in 2018 are even higher. So let's look at a common procedure, sleeve gastrectomy, a conversion of sleeve to bypass. What does the literature say? There are no randomized controlled trials, no meta-analyses, and the literature is filled with small series of 18 to 77 patients, and very few matched control or multi-center studies that are mostly retrospective that I'll share with you today. So these are the series you can see in the literature. You can see, if you look at the numbers, they're very small numbers. And in most of these patients, you look at the follow-up also, the follow-up is usually not long-term. So there are two multi-center retrospective cohort studies and one matched control study that I want to share with you today. So this is the multi-center study, 4-year study. Primary sleeve patients converted for weight regain. Some patients had conversion for reflux. And you can see that there was surgical complications in 10% of patients, 6.7% leak rate. So reoperative surgery is not without complications. Another large series from the Netherlands, from Frits Berends and Ido Arts group, looking at when you take patients with weight regain after sleeve, do you do a SADI versus a Roux-en-Y gastric bypass? And the major complication was similar in both groups. Nutritional deficiencies was a little higher in SADI, but the weight loss was completely different. The patients who had a SADI after sleeve gastrectomy did much better. The other question is, what's the long-term reflux rate? So in these patients, you need to make sure these patients don't have reflux. And in this study, despite very aggressive supplementation, there were still significant nutritional deficiencies in these patients. Another study looking at converting sleeves to BPD and Roux-en-Y gastric bypass, and showing similar that patients do better if they're converted to duodenal switch. But in cases of dysphagia and reflux, these patients do better with Roux-en-Y gastric bypass. We need to note that BPD and DS, as was shown in the Migroni trial, do better than Roux-en-Y gastric bypass, but at the expense of significant nutritional deficiencies. So the decision to offer DS and SADI has to be linked to the preoperative BMI, the socioeconomic status of the patient, and their ability to obtain follow-up long-term, be maintained on vitamins long-term, and their preoperative BMI. So this is a single-center matched series of about 4 years, and they matched primary and revisional Roux-en-Y gastric bypass patients. And the important thing is the revisional patients had lower weight loss and a little higher complication. Finally, I want to conclude by telling you our algorithm. We do an endoscopy in everyone, a barium study. And if the patient has reflux, we do pH and manometry if they have dysphagia. Obviously, dietitian, psychology, and look at compliance and labs. We look for a hiatal hernia, especially on the left side. We make a decision about the biliopancreatic limb, and this is a talk in and of itself. We use higher staple loads and oversew very freely. And then we don't make the Roux limb more than 100 centimeters because it's only needed for bile reflux. And as I said, we oversew everything. And if a patient has weight regain after Roux-en-Y gastric bypass, and we've checked everything, the anatomy looks good, we take them to surgery, measure their bowel, and divide the Roux limb, oversew that staple line, and move the Roux limb 300 centimeters from the ileocecal valve. Except if the patient's bowel are so long, then we make it as a percentage. So in conclusion, the take-home message is weight regain is normal after bariatric surgery. We need to know how much weight regain has happened and what are the patient's current BMI, comorbidities, as well as the risk status. The starting BMI and comorbidities are important because if the patient gets the wrong procedure, they will end up needing another procedure later on. And the notion of a staged approach is probably not the best thing to do. The optimal length for the BP limb can lead to more weight loss, but too long of a BP limb, as shown in the Omega trial, can lead to more malnutrition, not through just a general malnutrition, but it's the fact that the total alimentary limb length is now short. Super obese are at high risk for weight regain, like stage 3 and 4 cancer, and patients with super obesity need to be treated differently. Reoperative surgery has higher complication and lower weight loss than primary bariatric surgery, so it needs to be taken with experienced centers. If the disease of morbid obesity or obesity-related comorbidity is still present after primary bariatric surgery, I think additional therapy is reasonable, and this is the general approach practiced in medicine in other specialties. The patient has reflux, you need to objectively test for it, and if they have Barrett's, the best procedure is conversion to Roux-en-Y gastric bypass. And not all patients can afford the staged approach. I think this is important. Again, I want to thank you so much for your attention, for the invitation to do this virtual lecture, and I look forward to the next time I come and visit you in India. Thank you very much and have a great afternoon.